Hello, this is Dr. Mary Regina Boland, and I'm here to present our project, Fairness and Robust Interpretability of Prediction Approaches for Aging and Alzheimer's Disease. This project is a collaboration between the University of Pennsylvania and the University of Virginia. It's a subcontract from St. Vincent College from the University of Pennsylvania. The PIs are Dr. Aidong Jiang from the University of Virginia, Dr. Carol Manning, also from the University of Virginia, Dr. Li Shen from the University of Pennsylvania, and myself, Dr. Mary Regina Bowen from St. Vincent College. The area of need that our project focuses on is deep learning models show great promise but lack robust interpretable explanations of the results. They thus incur ethical and trustworthiness concerns that may result in the unfair treatment of patients. They are very robust in terms of their accuracy and prediction, but we need to have interpretable methods that will enable clinicians to be able to alter the treatment patterns with the goal of promoting healthy aging versus disease-related aging. Again, disease-related aging that we're focusing on is Alzheimer's disease and related dementias, or ADRD. Our first aim addresses the issues of fairness through debiasing methods that we will develop, and then we will focus on explainable machine learning models. The overarching piece of our work focuses on using electronic health records data. So both the patient health data related to their diseases, their laboratory results, their medications, procedures, as well as their demographics such as their age, their race, and ethnicity. We are focusing on the 65-year and older population because we want to compare healthy aging versus disease-related aging with the focus again on ADRD. Our cohort includes 70,300 ADRD patients and 1,671,560 patients that are 65 years and older. We were able to compare the two populations in terms of their demographics. I should note that this electronic health record data does come from the University of Pennsylvania, and we will also be using publicly available health-related resources for comparison, but we're focusing right now on electronic health record data from the University of Pennsylvania. Our ADRD cohort includes 54% female, and mean age of 82, with the min and max being 65 years to 90. Again, we capped that lower limit at 65 because we wanted to compare the elderly 65 and older population versus the ADRD 65 and older population. Regarding racial demographics, we had 65% that identified as white, 23% identified as Black or African American, 2% that identified as Asian, and 10% identified as other or unknown. And then we had about 2% of our population that identified as Hispanic ethnicity. We looked at our 65 and up population, which is much larger in size, 1.6 million, and we had 53% that were female, so very little difference in the female ratio. And the far right-hand column, we have actually the percent increase in ADRD, so we can look at that to see how much of a percentage increase is there in the ADRD population versus the 65 and older. And we see that a little bit less than 2% increase in females in the ADRD population, so not very dramatic difference there. The mean age was 79 years, so 3 years younger than the ADRD population. The white was 61%, so we have a slight increase in whites in our ADRD population, about 6.5% increase. And Blacks or African Americans, we have a dramatic increase. So almost 77% increase in the ADRD population versus our general aging population. The Asian rate is exactly the same, 2%, so there's no change there. And the other unknown is 24% in the elderly population. That's not ADRD, not necessarily ADRD. And this results actually in a reduction of 58%. So the other unknown racial groups go down in the ADRD group, which is interesting. The Hispanic ethnicity actually doubles, so it's a 100% increase because it goes from 1% in the general population to 2% in the ADRD population. To display this in a more pictographic way that might be easier for viewers to see, we can see that the Hispanic population increased 100%, Black African American increased almost 77%, and those were the two largest increases. And we also had this big decrease in the other unknown population over here in the far right of almost 60%. Asian was unchanged, female was barely changed in terms of the percentage, and white increased a very small amount, but not much. We will, as part of our project, develop fair and interpretable artificial intelligence and machine learning models to predict Alzheimer's disease. In addition to just healthy aging versus disease-related aging, we're also interested in looking at the severity levels of Alzheimer's disease, such as mild and severe, shown here, and maybe even looking at moderate. A key part of our research will be, in addition to fairness through debiasing, the second aim, which will be looking at explainable machine learning models. And hopefully our results will be interpretable for clinicians. And that's the reason for adding this additional explainable piece. Our study team and who we are, here's some pictures of us and our team. Again, Dr. Aidong Jiang with expertise in artificial intelligence and machine learning and health informatics. Dr. Carol Manning from the University of Virginia, expertise related to Alzheimer's disease and related dementias, among other things. And Dr. Li Shen from the University of Pennsylvania, expertise in artificial intelligence, machine learning, Alzheimer's disease and related dementias, and imaging informatics. And Dr. Mary Regina Boland, currently at St. Vincent College with the research affiliation at University of Pennsylvania, with expertise in artificial intelligence, machine learning, data mining with electronic health records, and informatics as well. Thank you very much for your time, and I hope you have a good day.